Now we can move on to our next talk for this particular session. The next speaker is Alex Michel. She is a postdoctoral researcher at University of Edinburgh, and she works with Professor Robert McIntosh. Over to you, Alex.
Sorry, I'm muted now. I'm going to talk about our work in about reaching in Alzheimer's disease. So when you typically think of Alzheimer's, you associate it with symptoms such as memory loss and degeneration in areas that we saw on the earlier slide, like the medial temporal cortices and hippocampus. But studies have shown that actually one of the first areas to show pathophysiological change that leads to Alzheimer's is actually the precuneus, which is in the parietal cortex. And these changes have been found to occur some 20 years before the onset of any kind of clinical symptoms such as memory loss. And the precuneus is part of a network of areas called the dorsal visual stream, which are critical for the online control of visually guided actions. And when the dorsal stream is damaged, it can cause conditions such as optic ataxia, which is a really specific disorder of online motor control, where patients have difficulty reaching to things that they're not looking at, so in their peripheral vision. So this video shows a really good example of someone who has optic ataxic symptoms. They can't reach to the rod when they're looking straight ahead, but when they're looking at the rod, they can reach to it perfectly. So because of that feature, these symptoms often go quite unnoticed because, when you reach to something in your environment, you look at it before you pick it up. So given that optic ataxia tends to go quite unnoticed unless you're looking for it clinically, and the changes and the functional changes that we see in the dorsal visual stream in Alzheimer's, we thought that individuals with Alzheimer's and MCI might present with similar symptoms to what we see in optic ataxia, so an extreme peripheral reaching deficit. So this is what we tested. And to do this, we used two different reaching tasks. The first, where we presented our targets on a laptop screen in front of the participant as so, and we got them to perform two slightly different conditions. The first we called free reaching, and it's when you present a target, you simply get the participant to look directly at the target and then reach to it, so just standard reaching. And the second condition is peripheral reaching, and the only difference here is we got our participants to look at the fixation cross throughout the entire reach, so straight ahead of them and reach the targets without looking at them. And it's in this peripheral reaching condition that we expect to see an inflation of reaching errors in Alzheimer's disease and MCI. Because this reaching task was presented in the lateral plane, so the frontal parallel plane, we call this our lateral reaching task. And here targets are presented in the far periphery at 3 separate target eccentricities. Our second task, we presented our targets in depth. So this is the display just here. So participants were reaching out to touch targets in depth. And we called this our radial reaching task because our targets are represented in radial depth. And here they were presented at 4 separate target locations from near to far periphery. And we again got them to do free and peripheral reaching as well. So to get an idea of how well our patients performed in the peripheral task, we calculated what we call a Peripheral Misreaching Index, or PMI, which is simply the absolute error for reaching to targets in free reaching condition, subtracted from the absolute error in the peripheral reaching condition. And once we had this number, we ran a case control analysis to identify substantial reaching deficits at the individual patient level versus our controls. And then we also ran a standard group analysis where we compared mean differences across our 3 groups. I'd just like to highlight that a lot of this analysis was done by a wonderful PhD student at UEA called Ali Warman. I just wanted to acknowledge her contribution to this project. So what we found when we're looking at just the PMI analyses, you can see data from our 3 participant groups here. And just to note that the higher the PMI, the worse the individual is at reaching to peripheral targets. The filled diamonds that we see here show the cases where they had a significant reaching deficit compared to controls. So that was our case control analysis. And as you can see, there's only 1 in each group here. So there's 1 MCI and 1 Alzheimer's patient who show a significant peripheral reaching deficit. And these crosses show the group mean. And as you can see, there's very little difference in reaching deficit across groups in the lateral reaching task. So that's our frontal parallel task. For the radial reaching in depth, we found a very similar result. So there are a couple more Alzheimer's patients who show a significant deficit and a slight overall inflation in peripheral reaching error, but again, very little difference across groups. So if we just look at accuracy, we can see there's actually patients with Alzheimer's cope quite well with peripheral reaching, and there's not much difference between their reaching errors and the control group's reaching errors. But there's usually a speed accuracy trade-off with these kind of things. So sometimes you slow down to compensate for any impairment that you might have in your reach. And if we look at movement time, which is the reach duration, so the time when they take their finger off the button and to when they touch the target, you can see that in both free and peripheral reaching conditions in the lateral reaching task, individuals with Alzheimer's are 100 to 200 milliseconds slower than healthy controls. And this is significant across groups. And our MCI patient sits somewhere nicely in the middle here, where they're significantly slower than our Alzheimer's patients, but significantly faster than Alzheimer's and significantly slower than our healthy controls. And this result is reproduced quite nicely in our radial reaching task, where we don't see as much difference between our patient groups, but there is about a 100 millisecond slowing in reach duration in our patients compared to our healthy controls. So what this suggests is that there is some subtle visuomotor impairment in Alzheimer's disease and mild cognitive impairment that's compensated for by slowing down the reach movement. So just to summarize a little bit, we don't find any evidence of any optic ataxic-like reaching deficit in Alzheimer's and MCI, but there is evidence for a slight underlying visuomotor impairment that's compensated for by slowing down the reach. And it'd be really interesting to look at further studies into peripheral reaching, more complex peripheral reaching, such as grasping or speeded response, to sort of piece apart the deficits that might be present in Alzheimer's disease. And finally, I just want to thank my team. So my PIs, Stephanie and Rob, the clinicians on the project, and the wonderful master students that were involved in data analysis and collection, as well as the teams at Rounding Clinic and the NHS, our funders, and also all the patients and carers that are involved in the project. And thanks for listening, and I'm happy to take questions. It's an interactive talk, so please, lots of questions.
Thanks, Alex. Do we have any questions from the panelists and the audience? Someone from the panelists may would like to go before? Yeah, we have a question. Marta is asking, would you consider another interpretation, for example, that MCI and AD have timing impaired instead of spatial accuracy? Interesting question. Yeah.
Yeah, no, that's a good question. So yes, I mean, we could. I mean, so to sort of really look into that would be interesting to basically limit the reach response the time that people have to reach. So, you know, sort of get them to reach within like 1.5 seconds or something like that, and make it quite a short response, and see if there's any spatial error impairment as well as a timing impairment there, and that will be able to piece apart that question. Yeah, so it's a good question. Don't know for sure just yet. So.
Any other question? Thank you, Alex.
I have a question as an answer for another question. Sorry.
Okay. So thank you, Alex, for the wonderful talk. And we next have Rana Kauri.